This meeting is now being recorded.
Well, again, good evening. Welcome to our EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker, we'd like to mention one thing about this webinar. It is adult content and images. We do not feel it's appropriate for children, so if you decide to have your children watch it, please watch it in the entirety to make sure you are comfortable with the information that your children might be watching. So again, it is adult content. It's presented in a very professional and informational method, but it is for adults. So again, before we get started, I'd like to tell you who we are, what is our program, some upcoming events. We'll introduce our speaker this evening, Jennifer Ortiz, and then we'll have a Q&A. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife passed away with breast cancer. I was a caregiver for my wife, Carol, who struggled with undiagnosed EDS for over 30 years. So we introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 80 groups to date. Each group is given their own free website with a link from the directory and map. We receive feedback that conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Tuesday, typically at 7:30 p.m. Eastern Daylight Time. All the programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you will find over 250 products selected by EDSers for EDSers. The store is the only funding for this program, and it usually covers our monthly web fees. Please visit our store and check out the helpful products that we sell. Just a general disclaimer, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911. Always consult your doctor before making any changes to your treatment.
Just to let you know about our upcoming webinars, on September 15, we have Dr. Joan Stoller, who is a clinical geneticist at Boston Children's Hospital. And on October 6th, we have Ellen Smith presenting using medical marijuana. This is similar to the presentation that she gave at the conference this year. For those attending live, there will be an opportunity for Q&A after the presentation. Please add your questions at any time by clicking the Q&A icon at the top of your screen. After typing your question, click the orange button to submit. I'm pleased to introduce our speaker for this evening, Jennifer Ortiz, and she has EDS herself. She has spoken at the EDNF Learning Conference this year and has a master's in physical therapy. She's certified in women's health physical therapy by the American Board of Physical Therapy Specialties and has experience in a variety of settings including sports, neuro, rehabilitation, geriatrics, orthopedics, lymphedema, aquatic therapy, osteoporosis, as well as male and female pelvic floor physical therapy. And she has also had classes in advanced manual therapy in visceral manipulation. Jennifer has served as clinical instructor for University of Maryland, Winston-Salem University, Howard University, and Rutgers University internships, and has presented many CE events, community education, and roundtable discussions on topics related to pelvic floor physical therapy. And she teaches classes on pelvic health and rehab at several colleges and universities. So we are just delighted to have Jennifer this evening, and welcome, Jennifer. We're going to load your slides on the screen, and I'm going to go ahead and turn over the microphone to you.
Okay, thank you so much, Deanna. I really appreciate the opportunity to speak on a subject that is something I'm quite passionate about, and that is physical therapy as part of a multidisciplinary care team for sexual dysfunction in clients with EDS syndrome. As far as my credentials, I am a board-certified women's health specialist by the American Board of Physical Therapy Services, as she just stated. And my only complaint about this particular specialty is that it really sort of sells short the male pelvic pain patients that I treat. I do treat male pelvic pain and male pelvic floor dysfunction in general, and certainly do not only limit my practice to females. The most important credential I have, I feel, in presenting this lecture at all is the fact that I was presented with my first client with EDS in 2006. This amazing woman was and is so educated in her condition, and she educated me, and together we worked to get her better. And as she spoke about herself, it also allowed me to further understand that it was likely that I myself had EDS. And I do. I also have POTS, and for those of you who do not know what that is, this is not the format in which to discuss that, but I certainly have a vested interest in better understanding EDS and better treating it within my clinic. Pelvic floor physical therapy in general, amongst other things, we treat hyperarousal or persistent genital arousal disorder, which is common in clients with EDS. We'll talk a little bit more about that. We treat pelvic organ prolapse. This means any of those pelvic organs. It could be the uterus, the urethra, the bladder, the rectum. The vagina itself can actually prolapse out. And to clarify, we do not reduce the prolapse specifically, but we do strengthen the muscles that support those organs and improve comfort significantly. We treat diminished or absent libido, and again, what we do is we treat the musculoskeletal portion of this, and we can improve libido by simply improving the pelvic floor muscle function. Most commonly here at our clinic, we treat pelvic pain, which is pain with intercourse, painful bladder syndrome, or otherwise sometimes called interstitial cystitis. Pelvic region pain, such as pain in the hips, the SI joints, pubic bone, tailbone, sit bones, or ischial tuberosity, and pelvic congestion, which is common in clients with EDS, or at least we find it's common. We also treat urinary and fecal incontinence, and a lot of you may wonder, well, again, why are you mentioning that? I'm here for a conference on sexual dysfunction. Why are you talking about urinary incontinence and fecal incontinence? Well, I would make the argument that sexual function is intimately related to urinary and bowel function, and that if any one of these systems is not working well, you have a high chance that the other is not working well now or will not work well in the future. And certainly many clients come to our clinic and they will say, well, I'm here for pain with intercourse, but, oh yeah, you know, I do have issues. I can't quite make it to the bathroom sometimes. Or more commonly, you know, sometimes I can't empty my bladder all the way. I try, but it feels like I still have urine inside of my bladder. And these things are common complaints that sort of travel together. So why does a physical therapist who treats pelvic floor dysfunction feel that she can speak to EDS clients? What makes it important to look at pelvic floor dysfunction in EDS? Let's look at the research. In the Journal of Reproductive Medicine, back in 1994, They published an article entitled Obstetric and Gynecologic Dysfunction in the Ehlers-Danlos Syndrome. And what I like about this study is that this was when the newly formed Ehlers-Danlos National Foundation, and so I like the idea this was newly formed at that time, back in 1994. These women were sent a very detailed questionnaire with 50 questions concerning family history and inheritance, past medical history, and obstetric and gynecologic problems. So even then, there was an awareness that there was a higher prevalence of obstetric and gynecologic dysfunction in clients with EDS. They had a woman respond, 68, and of the women that responded, their average age was 42 years, and at that time they were classing EDS in different types of, 1, 2, 3, 4, etc. They found amongst their various findings that recurrent vaginal infections occurred in 53% of the clients and sexual dysfunction in 61%. And they had this sort of blanket statement at the end of it that said, women with EDS also seem to have a high frequency of dyspareunia. Well, dyspareunia is a very fancy word for pain with intercourse. And let's continue on to the next study. In the American Journal of Medical Genetics, this was published in 2012. We've jumped way forward. An article entitled Gynecologic and Obstetric Implications of the Joint Hypermobility Syndrome in 82 Italian patients. And again, in this study, they found that the common gynecologic findings were dysmenorrhea, which is a fancy word for really painful periods, irregular menses, 46.3%, and then again, there's that word dyspareunia, and vulvodynia, which means pain on the vulva, which is the entrance of the vagina, at 31.7%. They also found that there were many complications common in the population, which included abnormal scar formation after cesarean or episiotomy at 46.1%, pelvic prolapses at 15.3%, and coccyx dislocation at 1.4%. Now, again, of course, the weakness of this study would be that there are only 82 patients, and it's certainly not multi-centered. And then in the Journal of Sexual Medicine in 2013, Dr. Jill Kraft and Andrew Goldstein, who are two pelvic pain physicians and gynecologists in our area, published a study entitled Two Case Presentations of Profound Labial Edema as a Presenting Symptom of Hypermobility Type EDS. And here they presented, I like that these were two young girls, a 25-year-old and a 22-year-old, who'd had intermittent labial swelling for quite a bit of time. And they were able to lead these patients to go and pursue further diagnostic studies and confirm that each one of them had hypermobility syndrome. And they were able to say, well, this certainly highlights the need for further research to determine the incidence of labial edema in hypermobility type EDS, and to further elucidate a potential correlation between profound labial edema and collagen disorders. And that's great. We know we do need to call attention to this condition. However, again, this is simply two case studies and not a large enough study to draw some serious conclusions. And certainly, if you read through the research, you will see that phrase again and again, we need more research, we need more research, we need more research. In the International Urogynecology Journal, published in 2013, an article entitled Lower Urinary Tract Symptoms in Women with Benign Joint Hypermobility Syndrome, a Case Control Study. I do like this study. They did have 60 individuals that were diagnosed with EDS, matched with 60 healthy women, so that was nice. They had a control group. And they found that the prevalence of urinary incontinence in those with hypermobility syndrome was significantly higher than in the control group, 73.3% versus 48.3%. They found that a significant number of women with hypermobility syndrome suffer from voiding difficulties, they worded it. They found that also prolapse of the anterior vaginal wall was objectively more severe in those with hypermobility syndrome. So women with hypermobility syndrome, they decided have a lower quality of life, and they felt that it was important to identify women who are symptomatic, and that the addition of a systematic active case-finding approach would perhaps be more effective in identifying these cases. The next study, and although again they have the same number of participants, this is an even better study. It was published in BJOG, which is an International Journal of Obstetrics and Gynecology, in 2013. And I will say that I had the privilege of seeing the editor of this particular journal speak at the last International Pelvic Pain Society conference. And I was very impressed with the rigid restrictions that they have and the sort of requirements that they have in order to be published in their journal. And so you can trust the articles in their journal as to their outcomes. The purpose of this study was to determine whether pelvic organ prolapse and sexual dysfunction are more severe in women with benign joint hypermobility syndrome than in the normal population. And in this case, yes, they had 60 women diagnosed with hypermobility syndrome and 60 controls, but the reason the study is stronger is, one, all the women continued to participate throughout the study, but all the women in the study group were matched with healthy control women according to age, parity, and ethnicity, which means that if they had, for example, a 40-year-old Caucasian woman in the study group, they had a 40-year-old Caucasian woman in the control group. And this allowed them to really compare the two groups more effectively. And so within this study, they found that significantly more women with hypermobility syndrome felt that their pelvic organ prolapse interfered with sex and defecation compared with the control group. And that the impact of prolapse symptoms on quality of life was statistically different in almost all of their quality of life domains that they looked at. This study published in 2014, I love this study as well because they looked at over 1,225 patients who reported a typed diagnosis of Ehlers-Danlos syndrome. So the large volume of participants in the study helps to me, again, validate this study's outcomes. And again here, amongst their various findings, they found that gynecologic pain that includes dysmenorrhea, which is very painful periods at 92.5% and dyspareunia at 77%. This means that 7 out of 10 women with EDS likely have pain with intercourse. They found that there is a much greater prevalence of obstetric and gynecologic issues reported by women with EDS than in the general population. They felt that physician providers should be aware and should counsel patients with EDS about their relevant options and risks. So we now believe that physical therapists who specializes in pelvic floor dysfunctions should be part of the EDS multidisciplinary care team. However, in general, I'd like to point out how physical therapy and EDS is doing in general. So just kind of the general physical therapy and EDS, and I will tell you it's not very good. In the Physiotherapy Research International, it's a journal for researchers and clinicians in physical therapy. They published in 2014, an article entitled United States Physical Therapists' Knowledge About Joint Hypermobility Syndrome Compared with Fibromyalgia and Rheumatoid Arthritis. And the aim of this study was to assess the United States physical therapists' knowledge about hypermobility syndrome, and then compare that to other more commonly presenting diagnoses, at least in the physical therapist's opinion. They found that only 26.8% of the respondents were familiar with the Brighton criteria for diagnosing hypermobility syndrome, and that very few respondents, 11 to 19%, even realized that hypermobility syndrome has extra articular features, such as anxiety disorder, fatigue, headache, delayed motor development, easy bruising, and sleep disturbance. Physical therapists working in environments most likely to see patients with hypermobility syndrome underestimated the likely prevalence in their patient population. So obviously not pretty. And at the Archives of Physical Medicine and Rehabilitation, published in 2011, they essentially found that only 63.4% of patients with physical therapy reported a positive outcome. Now, one could argue 63.4% is pretty high considering how little that physical therapists seem to understand about EDS, but then you could look at the opposite direction there and note that that means that 40% of those patients really did not have a positive outcome, and perhaps it was even harmful. And again, there you see that conclusion. The outcome of surgical and physiotherapy treatment, they did look at surgical outcome as well, is disappointing in a large percentage, which illustrates a strong need for evidence-based therapy. Again, that call for more research. So this article, you would think I would just love it, and in some ways I do. It was published in the American Journal of American Genetics in 2013, and it was a it was entitled A Multidisciplinary Treatment of Disability in Ehlers-Danlos Syndrome Hypermobility Type Hypermobility Syndrome, a pilot study where they used a combination of physical and cognitive behavioral therapy on 12 women. So basically, they point out that there is a lack of evidence-based treatment approaches, that few studies have shown the effect of physiotherapy, and that many authors propose multidisciplinary treatment, but this has neither been described nor evaluated for this patient group. So the aim of the pilot study was to investigate if a multidisciplinary rehabilitation program combining physical and cognitive behavioral therapy was feasible, safe, and effective for 12 women with EDS hypermobility type. So you would think I'd love this study. Well, some problems I have with it. Well, and for starters, it was a pilot study. A pilot study means that they're looking to see if this could be performed in a larger group of women and repeated. So that's simply what that is, and I have no problem with that. The difficulty I have with this study is the intervention. It consisted of 3 parts. The first part is that 2.5 weeks were spent in a rehabilitation unit with testing, physical training, group discussions, and lectures. The second portion was individual home exercises for 3 months with weekly guidance by a local physiotherapist. And the third, readmission for 4 days for further testing and training advice. Now, again, most of my patients could not afford to take 2.5 weeks out of their life and stay in a rehabilitation unit. Most of my patients could also not afford to go back for those 4 days for further testing. Certainly most of them could afford a weekly home exercise program with guidance by a local physical therapist, but it appeared to me that that initial 2.5 weeks was rather important within this study. So the study, unfortunately, I feel is at this point unrealistic and cost prohibitive for most clients at best. So I had to think about what could be done for EDS clients in the real world, the world where most of us have to work and study and pay bills and cannot leave and go to a rehab unit for weeks at a time. And I had to start with clinical reasoning and critical thinking and really combine this with my own experience as a physical therapist because really we practice on one another first and then we practice on our patients. And I had to think about when people were, quote, practicing on me, what made me feel far worse than what made me feel far better considering that I have EDS. And I felt, based on all of this put together, that there were some common sense approaches that could be applied to all EDS pain, and this includes in the neck, back, and shoulder, as well as pelvic floor dysfunction. The first thing I, sort of logically came to is that in treating pelvic floor pain and sexual dysfunction, but really, like I said, any place in the body, there should be no aggressive joint mobilization or manipulation, and I think the reason should be pretty obvious. We tend to be already hypermobile. Our joints are quite loose, and there is likely little need to increase the mobility of the joint and its mechanics. And usually if you do aggressive joint mobilization or manipulation, you're likely to cause muscles to become hypertonic or go into spasm because they're trying to guard from this hypermobile and sort of natural feeling mobilization to further support the joints after being irritated, which then leads to increased pain. Now, I certainly cannot see any of you at this moment in time, but I'd like to ask all of you to go ahead and make a really tight fist with your hand and simply look at your joints and kind of feel the pressure and the pain that you're experiencing in your hand. A muscle that is in spasm or that is hypertonic is just like that fist. Go ahead and relax your fist. If you looked at your fist as you were holding it, you might notice that there were areas of lighter skin color, and that's where you had lesser blood flow. Any muscle that's held in spasm or hypertonicity tends to feel very uncomfortable within a relatively short amount of time. And in a patient with hypermobility, we tend to exist with hypertonic muscles kind of turning on and off throughout our body depending upon what we're stressing at any given point in time. So again, we certainly wouldn't want to do anything that would provoke that process or make it even worse. I feel that you should realign joints, especially in the spine and pelvis, using gentle techniques where the client uses their own muscles to place themselves back into alignment. This decreases the risk of pain after treatment, and it tends to decrease anxiety in the patient because although the practitioner is choosing which muscles to use, the client is in control of how hard the muscles are contracted. And we will talk about this method later on in this lecture, but you could imagine it makes quite a bit of sense. Now, I will say that there is some argument against this method of treatment, and certainly I can speak to that as well later on in the lecture. But it makes sense to me that you would take and do your best to place a client in a place where it feels good, and certainly clinically. And I do think that way. I think mechanically and clinically, because this is where I live in the clinic. I have seen it work. I also believe that you should fully clear muscle hypertonicity and spasm and trigger point at each treatment, that it must be fully cleared or the client will feel even worse than when they came in, leaving than when they came in. The clinician can use max tolerable, and I emphasize that word tolerable. It must be tolerable without any patient cringing or guarding, mild fascial release and soft tissue mobilization, as well as connective tissue release. I think a lot of people tend to treat clients with EDS as if our entire body is made of fragile glass. And the truth is that firm pressure can feel quite wonderful, and that our joints may be terribly lax, but the muscles themselves could be quite tight and uncomfortable and really benefit from this kind of manual therapy. We also regularly use gentle techniques like strain, counterstrain to fully reduce trigger points. And there's that word internal. I certainly treat both internal and external when treating sexual dysfunction, and we'll talk about that more as this lecture continues. I also feel that we as physical therapists who treat pelvic floor dysfunction as well as any kind of pain or complaint should educate clients on the current forms and proper use of orthotics, SI joint stabilizer belts, and how to use a kinesio tape to augment stability at home, and teach you how to place it on and pull it off and all the different tricks to use. And we should educate clients on body mechanics and posture to reduce risk of re-injury. However, with a client that has EDS, simply saying, well, sit up straight, that doesn't always work. If you think about it, if you're not strong enough yet and you try to force the body to sit up straight, and the client with EDS, they're working way harder than the client without it because they do not have that passive support of their ligaments within their spine to help them hold their posture. And so they're really depending on their muscles to do a great deal of the work. And so many times, yes, you will notice clients with EDS slouching quite a bit more. And so then really what you're looking for is to try to spend more time in better posture and less time in poor posture, and to strengthen those muscles over time to be able to spend more time in that better posture. And believe it or not, this absolutely relates to pelvic floor function. The thoracic spine innervates a great deal of what happens in our pelvic floor, and if you slouch, it actually can irritate the autonomic nervous system and increase stress, and we'll talk about later on in the lecture how stress can be a very big problem for pelvic floor function. So posture is important. However, again, it needs to be presented and educated to the given to the patient with EDS and its sequelae in mind. I also believe that a physical therapist who treats clients with EDS should give very careful home exercises as well as exercises within the clinic, considering all the possible variables. We should consider, of course, the hypermobility, POTS, fatigue, vascular insufficiency, and insomnia. That poor client is coming in exhausted, and now we ask them to exercise. It is very difficult, etc. This is showing up very poorly on my computer, and what I can certainly do if it is poorly shown on your computers is to make it available to the website, I suppose, for download in the future. But essentially what this is an algorithm that I give to my physical therapy interns and coworkers, and have shown at various other lectures as to how it is that we treat pelvic floor pain. And as you can see, it is complicated, and quite frankly, as we have continued to work and use this algorithm, we've determined it's really not complicated enough. I think one of the important points within this algorithm, though, is the point at which, and I hope you can see it. If you cannot, I apologize. There's a point at which it comes time to treat the client internally. There's a lot that happens prior to that. But if you're trying to help a client achieve improved pelvic floor function, many times this may mean that you go intrarectal or intravaginal. And the first question we ask ourselves is, can the practitioner place their exam finger inside of the vagina or the rectum, and is it pain-free? If it isn't pain-free, then we go right back to the external treatments, and we continue there, and we work with our physicians. But if it is pain-free, then we go ahead and treat internal. So if you're getting physical therapy somewhere else, please make certain that they do follow this general idea that no pain internal equals gain. Okay? Here is a shocking photo. I suppose this is one of the difficult photos, or perhaps a photo that you expected. We are here to talk about sexual dysfunction. But the reason that I have included this photo is I want everybody to think about the fact that the pelvic floor is not simply a receptacle for the penis or for sexual toys. It is not simply a hole from which urine and stool pass, and it is certainly not simply a place where babies come out. It is all of that, but it is also a complex network of muscles, tendons, ligaments, nerves, and joints. And this picture can help you understand better why a physical therapist whose specialty is the musculoskeletal and neuromuscular system would be appropriate for treating pelvic floor dysfunction. Perhaps you never thought about the sheer volume of muscles that surround the vagina and clitoris, and in the male patient, the penis and scrotum. In this picture, I'm going to go ahead and turn on the presenter's cursor here. I'd like you to think about the fact that over here we have the adductors, which would be your inner thigh muscles, and how they attach here to the inferior pubic ramus, which is this bone right here. We've had patients, for example, that would come to our clinic and would say, you know, I have no pain whatsoever during intercourse if my legs are together. But if I open my legs, then I have really severe pain. Well, immediately we're going to think about the inner thighs as being something that could be contributing to that client's pelvic pain. When the adductor is opened and the legs open up, then this muscle that is quite tight over here will pull on this bone, which will pull on this muscle, which will pull the vagina tight. And this is kind of how, again, physical therapists would think mechanically, all right? Of course, sexual function is far greater involved than this. That is a very simplistic idea, but it's where we play our role in the treatment of pelvic floor dysfunction. We always need to keep in mind that the pelvic floor consists of several layers of muscles that cover the bottom of the pelvic cavity. It has three important roles: to support the pelvic organs, the bladder, uterus, and colon within the pelvis, to assist in stopping and starting the flow of urine and the passage of gas or stool, and, of course, sexual function. And it plays, again, all of those roles simultaneously. Here's another picture of showing how and why we would treat external pelvic floor pelvic region trigger points. These muscles have been shown to contribute and cause pelvic region pain. There in this picture is an image of a trigger point, and you can see if we press there that the client would feel pain deep inside. And so this is yet another example of why we would treat that adductor when we're treating pelvic pain. And in fact, one lecture that I attended at the International Pelvic Pain Society conference in Chicago, one of the presenters described the adductor and trigger points within the adductor as being the bus driver of pelvic pain. In other words, you could have all kinds of things contributing to pain with intercourse, and those things could be thought of as passengers on the bus. But if you cleared all the other passengers and you didn't clear the bus driver, which was that trigger point in the adductor, then the bus would keep on rolling and pain would be continued to be experienced by that client. Ways in which trigger points develop, I mean, the list goes on, and think about how many of these things a client with EDS could present with, where they really present with multiple ways that trigger points can develop. If you have a client with EDS who fell on their tailbone, or they experienced abuse, or they have incontinence, and then they had a yeast infection, and then they went cycling, and then they had a vaginal childbirth, you can imagine how one essentially trauma could build on the other, Add to it that number 16, which would be the joint hypermobility and instability, and you've got a very easy method by which trigger points can develop in the pelvic floor. There are 3 layers of muscles in the internal pelvic floor. They're listed here, and you can certainly Google those and look those up later. But we would treat this within that algorithm, always layer by layer, gentle, careful examination, careful treatment of all of these muscles and all of those trigger points. So let's talk about some of the techniques that I had mentioned specifically related to EDS clients and some of those methods that are housed within that algorithm that I presented to you, but perhaps it was difficult for you to see. The first is muscle energy technique. Muscle energy technique is a common conservative treatment for pathology around the spine, particularly the lumbopelvic, particularly for lumbopelvic pain. However, we certainly use it really along the entire spine where indicated. It's considered gentle, and it's for the restricted motion of the spine and extremities, and it is an active technique, as I described earlier, where the patient, not the clinician, controls the corrective force. So it's really nice. If you feel like, okay, I really can't push harder, well, that's it. That's what you do, and that works really well with clients with EDS. This treatment, again, requires the patient to perform voluntary muscle contractions of varying intensity in a precise direction, while the clinician applies a counterforce, sort of not allowing that movement to occur. Now, that is a very complicated statement right there, and there are muscle energy technique courses that go on for 3 days, and this is certainly not a lecture that's going to really teach you about this technique. I encourage you to read about it. I think in practical terms, you could say that essentially we're trying to create an origin out of the insertion of a muscle and sort of pull the insertion towards the origin. And that may not help clarify this technique, but essentially what we're trying to do is to realign the pelvis, realign the spine, and to create a comfortable length-tension relationship between the different sides of the body. The theory behind MET suggests that the technique is used to correct an asymmetry by targeting a contraction, for example, of the hamstring or the hip flexors on the painful side of the low back and moving what's called the innominate, which is part of your pelvis, in a corrected direction. And I do think it's worth noting, however, that evidence suggests that non-symptomatic individuals also have been shown to have pelvic asymmetries, which means that I could walk up to anybody on the street and say, hey, do you have any pain? And they could say, no, I have no pain. And I could say, well, can I check your alignment? And I may find that they are not only out of alignment, but severely out of alignment, and yet do not present with pain. So one could argue that I really shouldn't waste my time correcting alignment. Again, I live in the clinical world, and I see this in plenty of cases, especially my EDS clients, where I might even see them for only 15 minutes, and their pain is significantly reduced by simply correcting their alignment. I would also argue that you could say the same thing to spine surgeons, which is that they did thousands of MRIs, and there were just as many people who had no complaints of low back pain with herniated discs as people with complaints of back pain with herniated discs. The mysteries of pain and its behavior within our central nervous system, I mean, we just barely are beginning to scratch the surface in understanding. In this image, I'm again going to turn on my cursor. Up here we have pubic bones, okay? So the pubic bone, there's really two of them. Here we have our clitoris, okay? This is the urethra, this is the vagina, this is the rectum, and this is the tailbone. So stay with me now. It's a little bit diagrammatical, obviously, but I'm trying to make a point as to why correcting alignment might be very valuable for certain patients, and perhaps this can help you visualize it. Just for this lecture, let's imagine that this muscle represents a muscle called the pubo, in other words, coming from the pubic bone, coccygeus, okay? So it's a muscle that goes all the way from the front of your pelvis to the back of your pelvis. And I like the name pubococcygeus because it gives you an idea of where you're going, where you came from. Okay, so this person, she has hypermobility syndrome. She's doing okay, though. Everything's okay in her pelvic floor. She does not have painful intercourse. She has no real issues with urination and with bowel movements. But let's say she gets a job or she takes on cycling and decides to do a spinning class for whatever reason, and something happens to her tailbone, and she starts to feel pain, and she starts to have issues with intercourse, and she starts to have issues with bowel and bladder, and lo and behold, they go and they get an x-ray and they find that her tailbone has really shifted over to the side. So let's take a look at what that might look like. And again, this is a hand-drawn piece, but again, it's to try to help you visualize why we're thinking about correcting alignment as pelvic floor physical therapists. So here we have the tailbone shifted over here to screen right, Now think about the muscle, just this one muscle, just the pubococcygeus, and I just for fun made her pubic bone go out of alignment as well, just to kind of add to it since that's very, very commonly presented with our EDS clients. And think about the fact that as this has shifted up and this has shifted over, and all the muscles that are on this side that have suddenly been pulled very taut, and this muscle may spasm, it may become very lax, but this muscle here too, from the sit bone over here to the tailbone, has become very taut as well. And now suddenly we have a client with quite a bit of dysfunction, all because her tailbone shifted over. Okay? So again, you could see, well, perhaps she would feel quite a bit better if I very gently helped her tailbone come back here to center so we could go back to this existence, right? And now it isn't always as simple as this, and there are many other reasons that somebody might have difficulty and pain with intercourse. But again, kind of thinking mechanically and architecturally like I do as a physical therapist, this is my part in helping her become less painful with intercourse. Strain counterstrain is perhaps the most effective treatment that we have for pain with intercourse with really any client here at my clinic. But in addition to that, especially with our clients with EDS. Strain counterstrain was originally called positional release technique, which I quite frankly believe is a better name and should never have been changed. It was developed in 1955 by an osteopathic physician named Lawrence Jones. Strain and counterstrain is a manual therapy technique, meaning that the clinicians use their hands. We use our hands to treat muscle and joint pain and dysfunction. And it uses passive body positioning of spasmed muscles and dysfunctional joints, where we put them in a position of comfort or ease that shortens this sort of ascending structure, which could be fascia and could be muscle, as trigger points can exist in either tissue. The purpose of this movement is to shorten and relax these aberrant reflexes that produce the muscle spasm, forcing immediate reduction of tone to normal levels. And I cannot tell you how wonderful this technique is. Not presented within this lecture, but certainly very valid, is the idea of centralization of pain. And we do a lot of good for patients and their centralized pain when we press on a site within the pelvic floor musculature and vaginal mucosa, let's say, or intrarectally, and the patient says, ouch, that hurts, that's my pain right there. And then I move the hip joint or press on a certain site and then press on that same site internal, and the patient says, I can tell you're in the same spot, but I don't feel pain anymore. It is an incredible and out-of-body experience to feel pressure within the vagina but not feel pain. In fact, sometimes the brain has a really hard time, and it thinks at first, like, wait, oh, that doesn't hurt. It doesn't hurt. And you're sitting there as a physical therapist, not just improving muscle function, but really helping that centralized pain as the patient's brain sort of wraps around the idea that touch inside the vagina doesn't have to be a scary thing, doesn't have to be a bad thing. Look at that. It can be benign. And how amazing is that? So the gentleness of strain and counterstrain makes it safe and effective for treating very fragile patients. And that includes right there, you can see the pelvic pain patients. It's well recognized in those with excessive joint motion or hypermobility. And strain counterstrain is really valuable for the chronic pain patient. These are some images that I pulled off the internet of people performing strain counterstrain. I do like the positioning of the woman there on the left. She's releasing muscle called the iliopsoas, which is a hip flexor. I would have done it differently with the picture on the right, especially with the client with EDS. I would have pulled you closer to me. If I were the treating therapist, I would have supported your knee and not left it hanging. But you get the general idea. That man is simply sitting there in a comfortable position, and she is releasing his piriformis. Now, biofeedback is something that I'm asked about frequently, that and Kegels. And I would like to clearly state that biofeedback is very helpful at certain times. We certainly do not use it as a first line here at my clinic. This picture is showing somebody who's performing a Kegel and then relaxing, or performing here we're performing a multiple series of Kegels and then relaxing. This is a rose because some patients, they say, don't like to have, the very clinical looking bar graphs. There are multiple reasons we do not use it at our practice. One of them is that the electronic and computer is really, it's unpredictable, and impedance can be a big issue, which is very frustrating. But the other is you don't just hand somebody Kegels to treat their pelvic floor. There are so many cases where somebody is already hypertonic. Imagine in your mind that you have a very hypertonic elbow and your hand is sort of trapped up there by your shoulder because your arm is just bent up there and it's trapped there and your elbow and your biceps are in spasm. And a physical therapist came to you and said, well, I know what I need to do to treat your spasming biceps. You need to do a series of biceps curls. Sit there and just even if you can barely move it, it's okay. Just keep holding onto that barbell and curl away. Well, you would look at them like they were crazy. Of course not. No, the first thing you need to do is lower that hand down to your side, be able to relax your arm fully. Then if the biceps is weak, go ahead and perform biceps curls. Well, the same rule would apply for pelvic floor dysfunction. Do not simply go and perform Kegels. Do not just, look at some protocol on the internet and go ahead and just start performing Kegels. They need to be performed correctly. And they need to be, you need to have confirmation that you don't already have extraordinarily high tone. You can still have severe, and you will likely have severe incontinence and urinary frequency with your muscles in a high tone. I know that doesn't make sense, but trust me, if the muscle's already short and it cannot perform a proper contraction, it is exhausted. Imagine, again, holding a 10-pound weight all day, and then suddenly the equivalent of a sneeze or cough is the equivalent of putting down the 10-pound weight and now lifting a 50-pound suitcase. If you've been holding the 10-pound weight all day, you cannot now pick up this 50-pound suitcase. You will be too tired. So in the same way, I certainly wouldn't want you to have a really, to have the expectation that if you're leaking urine, then it must be you need to do Kegels. It could be that you actually need to learn how to turn off your pelvic floor, especially with EDS, as your pelvic floor muscles could have become hypertonic to try to support the hypermobile joints that you have in your sacrum and pubic bone. Okay? So again, biofeedback, it can be a useful tool when used correctly, but it's not necessarily the most important thing that a physical therapist can do. Rotational mobilization is another technique developed by Dr. Peter Phillips. At least this is the person that I know that has developed this technique. It's where you should assess myotomes, dermatomes, and reflexes. Now, a myotome, what is that? That is a group of muscles in the legs, arms, hands, etc. It doesn't really matter where, but it's innervated by a very specific nerve root. So you're thinking very logically as you comb through the lower extremity and the abdomen and the hands, and you start thinking about, okay, yes, I'm going to check foot strength when the patient's here for pelvic pain. Now, why would that be? All right. I might check, for example, ankle dorsiflexion, which would be innervated by L4, and recognize that the vagina is innervated by L4. And if I can treat the ankle, then I'm treating the vagina without even touching it. Dermatomes are the areas where you sense touch in your body in a very organized fashion that relate to the spine. And reflexes, of course, we're all familiar when the doctor kind of puts that hammer to the knee. Well, he's looking at a very specific location in the spine. So you would treat the spine at the corresponding level of any impairment that you found. So here's an example. Let me try to explain a little more detail. If the patient has pain in the tissues around the vagina and the rectum, the therapist might evaluate the bulbar cavernosus reflex to evaluate the S3-4 nerve root for involvement. If the patient's reflex is hyper or hypo-reflexive, it would indicate that potentially the patient should be treated in the spine at that level. Another option would be that, again, as I discussed before, I would evaluate the myotomes by testing the strength of the ankle dorsiflexors. That's the ones that bring your foot up. Your toe extensors, that brings your toe up. Toe flexor, that's curling your toe, or your hamstrings. These are innervated by nerve roots L4, 5, and S1 and 2, respectively. And again, those same nerve roots innervate muscles in the vagina and rectum, including the levator ani muscles, the urogenital triangle, the clitoris, and the vulva, amongst other things. So again, if I can treat the spine and improve the function of the toe extensors, for example, then I have just improved the function of the vaginal muscles without having had to touch the vaginal musculature. Now, in regards to the EDS client, the thing I love about it is that this is rotational mobilization. It's very gentle. And all that you're essentially attempting to do is to stimulate type 2 mechanoreceptors and therefore releasing serotonin and improving nerve root function, which improves the function of really everything innervated by that nerve root. So again, we have found this to be a very safe treatment option for our clients with EDS, done again within their treatment tolerance. Now, there are all kinds of concerns with sexual function, okay? Sex and sexuality is complicated. There is the psychosocial. What about the histories of abuse or trauma? There's socioeconomic. This leads to tongue-in-cheek acronyms like double income, no sex. People are just working themselves to death and they're exhausted. There are testosterone and estrogen issues, which we will talk about. But hormones are not the main neurobiological chemical components of sexuality. You have, of course, your neurotransmitters. The balance of excitation and inhibition is an important discussion. With excitation, you have your neurotransmitters like dopamine and oxytocin and norepinephrine. Again, dopamine is associated with attraction and seeking pleasure and reward, and when it's elevated, it tends to stimulate the anterior pituitary, which increases levels of estrogen and testosterone. And if you think about, well, there's also the inhibition side of it. Opioids can inhibit, but also serotonin. And serotonin, very nice thing, it tends to produce a sense of calm and mood stabilization. But patients with high amounts have decreased libido, impaired ejaculation, and anorgasmia, which means they really struggle to achieve orgasm. So theoretically, you could have the client who has hypoactive, hypo meaning low, sexual desire disorder. This may be a result of hypofunction of excitation, so low dopamine, for example, hyperfunction of inhibition, high serotonin or opioid use, or perhaps a mix of both. And of course, the opposite of that could be the persistent genital arousal disease, which could be, again, hyperfunction of excitation and hypofunction of inhibition, or a mix of both. And then, of course, we have our hormone discussion. Well, progesterone, high levels of which cause a relaxing or loosening of the supporting ligaments in the back, knees, and pelvis. Well, think about when progesterone elevates, typically right before your period. Well, the woman who already has relaxed or loosed supporting ligaments in their back, pelvis, and knees, now here she has elevated progesterone right before her period, even further relaxing and loosening the supporting ligaments. She's really not in the mood to have sex at that point in time. She's in quite a bit of pain there during her premenstrual cycle. Of course, again, as I just said, the higher level occurs right before your period. Well, it turns out there's higher level of injury risk right before your period in females. It also relaxes the smooth muscle of the intestines. And you're looking at clients who have EDS already having bowel impairment and bowel function impairment. Well, if you have elevated progesterone, then already a lot of women prior to their period will complain of intestinal discomfort and constipation and challenges. And so, again, this woman during this phase of her hormone cycle, or if she's on progesterone medication, she may not feel very much like having intercourse. So estrogen deficiency and sex, well, you could have changes in urogenital anatomy, shortening and loss of elasticity of the vagina, diminished secretions such as Bartholin glands and Skene glands, increased pH, which makes you more alkaline, so it doesn't fight off bacteria, as well as an acidic environment. You could have thinning of vaginal epithelial layers, and you could have reduced blood flow. And mind you, you really do not have to have gone through menopause in order to have very low levels of estrogen. And, so it's something to keep in mind, but you certainly don't necessarily want to run out and get some sort of hormone replacement therapy without really carefully testing. And that especially applies to testosterone. Yes, it is the hormone of desire. It is made in the ovaries and the adrenals. 3/4 of it does turn into estrogen, and you do lose 50% of your testosterone after menopause. It does activate the sexual circuits in the brain and promotes healthy sexual desire. But here we have stress. And if you think about the fact that women with EDS and men with EDS tend to have higher levels of stress and anxiety, well, it causes excessive cortisol release from the adrenals, which suppresses the ovaries and their function. So here you can see where you could have a downward spiral. You could have decreases in estrogen and testosterone production. In fact, many of us perhaps have heard stories of women who were so stressed out that their periods stopped entirely. Well, again, this was originally, I'm sure, meant to be a protective reaction. Clearly, a bear must be chasing you. Why else would you be so stressed out? And so let's stop these ovaries in their path and go ahead and lower our testosterone and estrogen levels. Well, yeah, this woman is really not feeling like having intercourse. Stress, of course, decreases sleep, and in the client with EDS who already is at risk for insomnia, they're miserable. It increases generalized pain, which disrupts sleep and causes increased muscle tension. Think back to that fist effect, and we've got that sort of, perfect cloud of dysfunction and pain with intercourse. Sexual concerns for clients with EDS would, of course, then be lack of sexual interest and desire, lack of orgasm with intercourse. And it could be that there's weak or spasming muscles, leading to this again. Difficulty finding a position and performing pelvic movements. And fear of pain with penetration, or fear of deep pain, as well as actual pain, of course. And fear of orgasm or no orgasm due to the onset of pain afterwards, much less any kind of weak or spasming muscles, and diminished lubrication. And then, of course, then you have your hip and pelvic and back pain, which really one does not feel very much like having intercourse if the rest of their body hurts. So how can you get better sex? Now, of course, you could let go of a goal-oriented approach to intercourse. There is an acronym called VENUS, which is very erotic, non-insertive sex. And there are many, many websites with all kinds of suggestions you can go to. I think it's an important perspective that you let go of penetration as the end-all goal in tolerating intercourse and defining sex for you. Let go of a goal-oriented approach to orgasm. Consider that making your partner's body your personal playground is quite a bit of fun and is a wonderful bonding activity, and you can certainly let go of this sort of more goal-oriented approach. And enhance awareness of your erogenous zones, really educate yourself. There are way more than you might imagine. Communicate your likes and your dislikes, and educate yourselves about the anatomy of the pelvic floor, and even consider fantasizing. Use water-based lubricants, no Vaseline, baby oil, or mineral oil, no glycerin. Avoid, if you can, the spermicidal lubricant. Please try to use a different way to have birth control. Now, I do mention KY Jelly. It's not that I have anything against the brand. They actually do sell a good brand, a good type. KY Jelly actually has one that's water-based. But many of the KY Jellies are, they contain things like propylene glycol, which I thought was rather entertaining. That a recent dog food commercial that I saw showed, a little dog with a sad face and a sign that said propylene glycol, and something to the effect that you wouldn't want your dog to eat this, would you? And certainly if you wouldn't want your animal to consume it, you do not want to place it inside of your vagina. So please read your labels and try to think about the consequences. I only put this website up. I have no connection to this website. It's simply one website amongst many that has water-based, glycerin-free lubricant options. There's certainly old-fashioned ones like olive, almond, or grapeseed oil. And you could certainly, for our EDS clients especially, use supportive cushions like the Liberator. The Liberator, again, you can Google this website. They sell very specific cushions that really support you and allow you to have less pain and a little bit more variety with your sexual positions. Also, get advice on positions to avoid dislocation during intercourse. Work with your physical therapist, who's a pelvic floor physical therapist, and ask them to show you, because it really doesn't apply to everybody, but to show you what positions might work for you, considering your specific needs and concerns with where you may have increased hypermobility or pain, okay? A physical therapist's goal for sexual dysfunction We hope our patients have increased awareness and proprioception of their pelvic floor joints and muscles. We would like to decrease those fears of penetration, also desensitize those painful areas, improve continence and or avoiding dysfunction, prolapse and back and pelvic pain to reduce fear, normalize the muscle tone, improve the voluntary muscle relaxation as indicated, and then address any loss of sensation through which methods we can. And most importantly, it is to work with physicians who can address hormonal issues, neurotransmitter issues, urologists familiar with pain, urogynecologists, and gastroenterologists. My personal proposal for physical therapy treatment of sexual dysfunction in clients with moderate to severe EDS has very little current research to support it and is based on my own common sense and critical thinking and clinical experience. I believe first we should check and address alignment. I believe that placing those muscles, as I showed you in that very diagrammatical drawing, into an optimal length-tension relationship when right is compared to left just makes sense. And so this will be the first step for me and within our clinic. I will improve muscle function and normalize reflexive function along myotomes. As we discussed what those are, that would be, again, groups of muscles innervated by the same nerve roots in the spine by addressing the spine. And in doing so, focus on the areas that the client has come in to receive treatment. I would then decrease muscle hypertonicity, spasm, trigger points, and connective tissue restrictions using strain counter-strain first, and then mild fascia release, soft tissue mobilization, connective tissue release, etc. And again, if you're coming in for sexual dysfunction, you may be surprised that I treat you with this type of treatment around your thoracic spine. But most of the time, I will be treating you around your pelvic region, thighs, buttocks, and abdominal region. Provide support where needed in the form of orthotics, belts, and kinesio tape, as well as giving careful therapeutic exercise, always starting with isometrics, and then only stretching where indicated, and then progressing to higher intensity strengthening slowly but surely and carefully. And finally, again, my dream. Again, please don't ask me to name these EDS fluent physicians, but my dream would be to work with EDS fluent physicians and pelvic pain specialists to augment sexual function sooner than later through the use of careful medication, injections, nerve blocks as indicated. And then again, work with EDS fluent psychotherapists to deal with the potential PTSD. And I don't care whether pain with intercourse for any of our clients was something that was trauma because of abuse, or if it was in a loving relationship where they first experienced severe pain with intercourse. It doesn't matter to your pelvic floor how the trauma was experienced. It only knows that when you attempted penetrative intercourse, it was severely painful. And so then essentially your partner comes close to you again, attempting penetrative intercourse again, and what will happen? Your body will tense up and guard, and you may feel that autonomic nervous system flight or fright kick in, and this is where working with psychotherapists who know how to deal with this PTSD, as well as any other previous trauma, would be very helpful in the treatment of pelvic floor dysfunction methods, okay? So that is the end of my lecture, and we have this one photo here, and the photo is Kristen Joyce, and she's a doctorate of physical therapy from University of Maryland. Then you have Stephanie Deming with the blonde hair there, the shorter blonde, and again Deming McKay, Stephanie Deming McKay, and she has her doctorate in physical therapy from the University of Baltimore as well. I am the tallest one there in that photo with the big smile, and I graduated from Loma Linda University, and then we have Jill Arnold, who has her doctorate in physical therapy also from the University of Baltimore, Maryland. University of Maryland, Baltimore. Not shown in the picture is Samantha DeFlo, Amanda Marino, and Lauren Collins, who also has all three of them doctorates in physical therapy. And the office staff that save my life every day pictured there are Jessie and Denise and Luann. So without further ado, I will go ahead and turn to your questions. So let me open up the question page.
Thank you, Jennifer. We're so appreciative of the manner in which you handle this delicate, the delicate issues, and it's just amazing all the additional information you can provide to us. A lot of us didn't realize the surrounding issues, the back and the pelvis and all that, and how those might be involved as well. So yeah, let's go ahead and start with the questions if you can.
Okay. Okay. So the first question here is, my coccyx is loose from numerous injuries. It says, for years it's been veering off to the right whenever I tighten my buttocks during any sexual activity, but I can't help but tighten my buttocks during sex. And it appears here that my coccyx sometimes rotates as well. It stays painful until a chiropractor can straighten it. Sex was always causes the painful problem, and prolotherapy didn't help. Any suggestions? So it is very, very difficult when you have a highly unstable tailbone. We have physicians that we work with in our area who help to manage the pain in those regions, and they've done so quite successfully. And I don't believe that presenting those names in this current format would be very helpful, but I do think that having those injections for certain tailbones is very important in order to be able to minimize the inflammation and allow for the patient to go ahead and strengthen the muscles around the tailbone. Now, for the first question where they said that they cannot help but tighten their buttocks during sex, you're absolutely right. It's almost impossible to avoid that. And what we're currently having a great deal of success with is very careful training of the muscles around the tailbone. And just yesterday, I saw a male patient with really severe tailbone pain when he first came to us. And what we were able to teach him to do is, in his particular case, the big issue was that when he would contract his pelvic floor muscles and buttocks, his tailbone would flex forward and to the left. And through treatment, we've been able to make it so that his pelvic floor muscles and gluteal muscles could contract, and the tailbone remained in a neutral position. Now, again, this worked with him. I have had it work with others, but there have been patients where it's been very difficult and a long process to get that to sort of work properly, and sometimes can be very challenging because you have to have a lot of patience, and muscles don't grow overnight. I really wish they did. If my abs could become a six-pack abs in 4 weeks, I would have had them already, because that's about the time that I fall off of my exercise plan. Unfortunately, it takes time for muscle to grow. It takes even longer for weak and poorly used pelvic floor muscles to grow to support the tailbone. And I'm sorry that the physical therapy was not helpful prior to this, but certainly, I wish you the best of luck in this case. I mean, the tailbone, again, is a challenge. It's a challenge for us, too. If we care at all as physical therapists, it is a big challenge. Who does this type of work in the Boston area? There are multiple sources by which you can find physical therapists who treat pelvic floor dysfunction. How familiar they are with EDS, I cannot say. But the physical therapists are easy to find. One of the first places you could look would be www.apta.org. This is any physical therapist who belongs to the American Physical Therapy Association, which I know a great many who are not, but this is one way to find one group of physical therapists who treat pelvic floor dysfunction. When you get to that website, there's a tab at the top that says Find a PT. You click on that tab, and as you scroll down the page, it will give you options. Now, again, unfortunately, the APTA chose women's health to be pelvic health. Okay, so if you're a male patient, you still have to select women's health. That is the tab you select. But go ahead and select that tab, women's health, and it will give you the option to type in your zip code and then just how far you're willing to drive. And it will, when you hit Find That PT, then all those names will come up. And I would look on the APTA website just to be safe for the same credentials that are after my name, which is the WSC, which means Women's Specialist Certified, Women's Health Specialist Certified. And that can direct you to someone who treats in the way that I treat. Another option is to go to the Herman and Wallace website. They, I believe, have a list of practitioners. That is Herman, H-E-R-M-A-N, and Wallace. And then another option would be the Pudendal Info. And Pudendal Info, they also have their practitioners that they've certified with courses that they offer to treat pudendal neuralgia. Okay? Can't spread my legs wide due to chronic groin strains. So which intercourse position is safest to try? Yeah, you know, it gets tough because in the beginning, as we're giving these recommendations to patients as to which positions are safest, many of them will say, well, I've already done that and that and that, and I'm bored. I wish I could move on. Without seeing you and without treating you, of course, the safest positions would be those lying on your side. You would hope that your partner can kneel if your bed is low. He could kneel on a pillow and go ahead and penetrate with you on your side. This gives opportunity for breast stimulation and improves orgasm potential. There's also lying completely on your stomach with your legs straight. And again, it's difficult to achieve initial penetration, but once the penis has been entered into the vagina in that position, again, it can be quite stimulating, quite erotic. Another is with your male partner on his side and with your legs draped over him, if that makes any sense as well. Again, in all of those positions, your legs are together, and you tend to be in a more relaxed position. It doesn't allow for sometimes as aggressive pressing as some patients would prefer and love, but again, it can offer a little bit of variety. How with the muscles in severe spasm? They lock the joints. So if you take meds for that, that alone can stop any means of attempting activity. I have found ATP helps, but can't afford the physical therapy with Medicare, and yes, it affects internal and external pain. I don't know if I can speak to the ATP. I'm not certain what that acronym stands for. Now, the physical therapy with Medicare, that would surprise me. We certainly treat quite a few patients here on Medicare, and I guess the key would be there if you're secondary. If you do not have a secondary and you cannot afford the copay, then that does become quite expensive. Yeah, I guess I'm trying to understand the question. Maybe type that in at the bottom there. It says here then, for those of us without adequate gynecological care or whose doctors have given up on them, what are some specific symptoms that indicate pelvic floor physical therapy is appropriate treatment versus endometriosis, interstitial cystitis, etc.? You know, I'm getting to the point in my career where I'm beginning to believe that if you have endometriosis, if you have interstitial cystitis, you are probably an appropriate candidate for physical therapy, regardless. At least go to that first visit and let them rule out whether or not you need physical therapy. We are ethically, we must not treat you if you are not a good candidate for PT. So, our ethical guidelines are very clear. If we look you over and we say, nope, look at that, everything is very, very healthy, sometimes we'll determine that in our history. As we're even just talking to you, we'll determine, this client does not sound like a good pelvic floor candidate, but I'll still evaluate them just in case. And if they are not, then it is my job to refer you on to the appropriate specialist. And I realize that there are limitations in certain areas of the United States, even, city to city, there are limitations. But if you see a good physical therapist, they will let you know where you should go. However, again, I would argue that the majority of clients would benefit from physical therapy regardless. Do you work on spinal alignment in conjunction with hip-pelvic? Oh, yes, absolutely. The answer to that is yes, I do work on spinal alignment in conjunction with hip and pelvic alignment. This next question says, we have been told that pelvic PT should not be done until regular PT is well established. Pelvic therapy has been stopped twice because of the feeling that it was detrimental in absence of regular therapy. The lack of knowledge with EDS, which you referenced, ends up with a lot of bouncing around different therapists. The frustration has led to not pursuing any therapy at all. And what is your opinion on this? Yeah, I mean, that is unfortunate. And there is the occasional client, even within our clinic, where we will say to ourselves, you know, I think for a while I need to focus on your back more so than your pelvic floor. However, we don't typically stop the pelvic floor entirely because treatment of the pelvic floor can help the back and vice versa. The lack of knowledge with EDS is a personal mission for me, and in the hope that my profession will improve and that if a future study were to be repeated, that more physical therapists would be aware of EDS and its prevalence. I just, you know, my heart breaks for you with the bouncing around to different therapists. You know, I wish I had a better solution. Again, I can only speak in my own situation, which is that I do make an effort to train my staff regularly, as well as to regularly have, you know, team meetings discussing it and to try to educate others within my field. But that is about all I could say about that. Again, maybe if the people at EDNF could start some sort of listserv, you know, clients or physical therapists that they feel have a good awareness of EDS, perhaps that would be something they could take on as yet another task. I don't know. Here it says, my pelvis is hypermobile due to a serious motor vehicle accident. I've had lots of prolotherapy to my SI joints, but it hasn't stabilized my pelvis. Are there ligaments in the front of the pelvis which can't be injected that are preventing stabilization? Short answer, yes, absolutely. The anterior sacroiliac joint is something that can be treated and accessed intravaginally. And I am completely unaware of prolotherapy being performed on the anterior SI joint. But what an interesting thought and conversation to have. Certainly there are many physicians that do intravaginal injections of all kinds, so it's not like it would be completely unprecedented to do an intravaginal injection, but what a very interesting thought that would be. But yes, the answer is yes, you have many anterior ligaments, and again, one of the more important ones being those anterior SI joint ligaments. Would this mean if you had a slipped or herniated disc of L4-5 and such where nerves are pinched that this could have a role in pelvic pain? Yes, absolutely, even into the thoracic spine. The one can lead to the other and lead to the other and create that downward spiral. So yes, again, when we are assessing the client, we would be looking for significant impairment of their L4, L5 myotomes, right, and dermatomes. And so a good physical therapist will have already noted that and begun to treat it regardless of confirmation of that herniated disc or not. But most certainly it will play a role in pelvic pain. Any thoughts on the inability to orgasm following surgery, hysterectomy, specifically a 20-something woman without previous problems? Yeah. So we have quite a few cases like this, and each case is unique. You know, it's difficult to say that there's some sort of cookie cutter strategy or resolution to these kinds of issues. For example, we'll have clients where they've had a hysterectomy and a urethral suspension, and we finally figure out that really it's the urethral suspension that was the issue, and it's because it covered up the female prostate and therefore made orgasm very difficult. The clients where they've had hysterectomy, sometimes there has been disruption in the function of the muscles and nerves that innervate the clitoris, dependent upon, you know, how the hysterectomy was performed. Again, as a physical therapist, what we do is we treat what we can find. We treat what we can feel. We treat what we can measure. And we hope that it improves their capacity to orgasm. And again, many times it does. But that's all that we can do. You know, we obviously can't undo the hysterectomy, but if we feel scar tissue that could be impeding orgasm, we treat that. If we feel muscles that are in spasm ever since the hysterectomy and therefore have limited blood flow to the clitoris, we treat that. So but it is common, unfortunately. And I think some of the people at the ISWISH, which is the International Society for the Study of Women's Sexual Health, they comment on that quite frequently. Any suggestions for perpetual problems with UTIs, blood in the urine without infection, yeast infections, etc., with the feelings that are all related to sex? Yeah. So the beautiful thing is when a client is coming regularly to physical therapy with EDS, we're able to see a reduction in the frequency of UTIs. As I mentioned within the lecture, one of the things about muscles and spasm is that decreased blood flow. Well, decreased blood flow creates what's called an anaerobic environment. So that anaerobic environment, bacteria just loves an environment that has low oxygen in the blood. I mean, it just loves that stuff. So if you have poor blood flow in any given area because of muscle dysfunction, then you're more prone to the UTIs. And yeast infections as well. I mean, yeast just loves an anaerobic environment as well, which is, again, why after menopause you may see an increase in UTIs and yeast infections. So for the client with EDS, who's already experiencing these issues, this can be quite disheartening. But improving blood flow to that area, improving circulation, decreasing muscle spasm, again, this is the area in which physical therapists can help with that issue. Again, we treat what we find. We treat the muscle spasms. We treat the pain with intercourse, and you would really want sex to be something that is pain-free and would not introduce opportunities for infection. Again, another reason that an EDS client has an increased risk for UTIs is the ligaments that support the urethra are also lax, and the urethra drops down just that little bit. So if you could imagine when you're laying on your back, your urethra is closer to the opening of your anus, and therefore just that little bit closer increases your risk for infection. So it's very, very difficult. But again, if you can improve the health of the muscles, like the compressor urethra and the urethral sphincter, which helps support the urethra, well, then you can help do the work of the urethral sphincter, if that makes any sense. What is the relationship with a GI specialist? Yeah, I mean, bowel dysfunction, constipation is so important in sexual function. And working with our gastroenterologists is so important. It's very difficult to find a GI specialist, though, who sort of understands and treats pelvic floor dysfunction. I'm looking for that magical gastroenterologist. They do exist, the dual specialty, but I haven't found them just yet. It seems to be very controversial whether to reduce muscle spasm as part of treatment or to strengthen muscle and allow the spasm to reduce naturally once joint hypermobility is reduced. Any advice? As I said within the lecture, my personal bias is to reduce the muscle spasm as part of treatment first, which then allows the muscle to work more naturally and therefore increase it in strength very quickly without any pain. Now, there are the rare clients where I will attempt to do this, and no matter what I try to do, it just doesn't seem to help, and lo and behold, I try to actually have them perform a contraction, and the client feels better, and I should have done it from the beginning. I just feel that I would rather err on the side of caution, and there are several articles on a shortened pelvic floor, and if you would like the reference to those articles, I can certainly provide those to Deanna Ham, but those are the articles that influenced our treatment perspective. One of the authors was Rhonda Cotarinos, based in Chicago. It's a fantastic series of articles which really helped us rethink how to treat pelvic floor dysfunction, but that's certainly the direction from which our clinic practices and myself. What about the research done with knee bracing showing that wearing braces too much induces hypotonia? Is this not always the case? So, very good question. I would love to see that research with the knee bracing. There was a study that I read a while back, which I do not think I could quickly pull up that resource. That would take a little bit of looking, but I was very excited when I read it. And it was a study where what they decided to do was to place an EMG sensing device, which means it's a device which senses muscular activity. They decided to place this device on the low back muscles and the lower abdominal muscles underneath the brace. They did this on clients wearing the brace and clients without the brace. And in that particular study, it was very obvious that the patients engaged their muscles more when they wore the brace. Really, braces don't stop the knee from bending very much. I don't know if you've noticed, but there'll be football players wearing expensive knee braces, and yet their knee will dislocate and bend, RG3 being a great example of this. So really what the knee brace is doing when it feels so good and you put it on and it's so supportive, in my opinion, is helping you better engage your muscles. It's almost like a neuro re-education. Same with the abdominal brace or the SI joint brace. Now what will happen is you will get tired of wearing that brace typically, and there's multiple reasons for this. Again, just thinking practically, you know, if you wear tight socks, pretty soon you don't want those tight socks anymore. It feels uncomfortable. Your skin gets really tired of that pressure. And the same with any brace. Your skin and your fatty tissues will finally signal to you, I'm done with this. I don't want any more pressure. And so you'll want to maybe take it off. But then after a while, you'll start to feel pain again. And so then you'll want to put it back on. And again, follow your own body's leading. But in my opinion, I do not believe it induces hypotonia. Unless the brace has braced you in such a way that it's not allowing movement of any kind and inhibiting muscle function, then you might want to be more concerned. And so I guess, again, there is no cookie-cutter response, and each brace would have to be assessed on its own, separate from others. Is there anything published on this that I could provide a pelvic floor therapist who does not know much about EDS? You know, I presented the studies that I could find that seemed to me to be the best amongst the studies. I'd start with the studies I presented in this lecture, but again, no, that's the short answer. Not much. I think that the physical therapist may think through some of the points I've made in my lecture and then, you know, perhaps debate it and then give me a call. And I'm certainly open to that. Any guidance on patient awaiting treatment who experiences extreme pain nearly every time, 70% plus using the restroom? Catch-22 because need to drink probably as much fluid as possible with POTS, yet urination is extremely painful, and this creates a pain cycle that leads to syncope. Oh, my heart's breaking for you. Yeah, again, I would treat that pain first. I would treat the muscle impairment first, and I would certainly want to make sure that you were working with a qualified and most excellent urologist who treats pelvic pain. Because it would be my belief, I certainly do not want you to cut down on your water intake for all kinds of reasons. So really, you would want to make sure to find those, you know, that urologist who treats pelvic pain and that physical therapist who treats pelvic pain so that you could reduce that pain that you have when you're using the restroom. And I'm very sorry about your story. I have herniated discs in my neck and at least 3 to 4 in the lower back. Do those have to be fixed before the type of physical therapy you do? No. Again, it would all depend upon, for example, if the herniated discs in your neck inhibited you from laying on your side or laying on your stomach or laying on your back within a physical therapy setting, well then unfortunately the answer would be yes. I need you to be able to lay on your side, stomach, and back, at least 2 of those positions in order to do what we do. But if it didn't prevent you, as long as we had proper pillows and different things to support you, and certainly the 3 to 4 in your lower back would certainly not preclude physical therapy for pelvic pain. In fact, we would likely treat both at the same time since, as I've discussed, treating your low back would help your pelvic floor pain. Would having my crooked coccyx removed be beneficial or prohibitive for stabilization? My instinct is prohibitive. I am concerned in a client with EDS with scar tissue development and changes in blood flow, muscle spasms in relation to the surgical procedure, I would just be very cautious. And there are other physicians who treat the tailbone and do all kinds of things before they have their coccyx removed. Now, I would also say that I may be very biased. Certainly, the only clients that we see here for coccyx removal are the ones that really go badly, right? So I may have a very skewed perspective, and therefore you may wish to interview other clients who've had their tailbone removed and hear their story. But certainly from my perspective, it has been horrible, their rehabilitation extensive, and some of the changes very difficult to address as a physical therapist because they were obviously permanent. So many of your pelvic floor muscles insert on the tailbone, and so to take it away and re-anchor those muscles, I mean, it's very, very difficult to treat at that point. You make it almost impossible if you do find that physical therapist, let's say a year or 2 years from now, to then treat you because you've taken out your tailbone and now there's not much that they can do to address it, if that makes any sense. What is the interplay between pelvic congestion syndrome and the treatment method you've outlined? I understand PCS may be a form of pelvic POTS. So pelvic congestion is very similar. It's just basically an exaggerated form of the muscles in spasm that I discussed, which is that there is a terrible ischemia, essentially, that develops, which is poor blood flow. You have these veins that are poorly returning blood back to the heart, and therefore the blood that's pooling in the pelvis is poorly oxygenated, and as I've discussed, poorly oxygenated blood creates a pretty severe pain. Poorly oxygenated regions create pain, and pooling of the blood in those regions creates pain as it applies pressure. And so when I'm treating a pelvic congestion client, again, my effort is to improve the muscles that support those veins and helps those veins return blood flow back to the heart and kind of keep things moving, as well as, again, to decrease those muscle spasms that could contribute to pelvic congestion. So a physical therapist, that's what we do for pelvic congestion. And again, we've been very successful within our clinic treating it. Now, in its relationship to POTS, again, I'll allow someone else to speak on pelvic POTS, as that is a little bit outside my real estate. Pelvic pain on arousal, during orgasm, after orgasm, all internal in the area of the uterus, and different pain with penetration. Are these things pelvic floor PT could possibly help? Again, I would say at least give us a chance to do so. You know, we are conservative intervention, and we have no serious side effects. Either we help you or we don't. And we have helped so many people with this that I would say at least give us a chance to try. Again, one of the definitions of orgasm is a maximal contraction and relaxation of the pelvic floor muscles in fast succession. So again, if those pelvic floor muscles aren't healthy, then it's going to be very, very painful once you achieve orgasm through one means or another, and the pain that can develop afterwards is sometimes astonishing. I did not realize Medicare would pay for. I do have oh, okay. I'm glad to hear that. Yes, we do. At this point, Medicare is covering pain with intercourse. It does consider that a basic activity of daily living, and I'm very grateful for that. I hope that never changes. My wife has been on opioid pain meds for what we know is pelvic floor and IC. The goal is to get off of the pain meds, but it is extremely difficult while also trying to maintain a minimal quality of life. A, is it reasonable to stay in pain meds while trying to get treatment? And B, as you shared, it can take time to build muscles. What is a realistic time frame to have as a goal to get off of long-term pain meds? Yes, it is reasonable to stay in pain meds, and in fact, I find it to be quite helpful if a client has their pain medications in place so that, you know, if you've been already using them, and then, you know, some of the things that, you know, even if on the pain meds, there are things that still hurt. So then if we can get rid of the pain in the things that still hurt, then you can go ahead and start walking down your pain medications nice and slow. And then you know what you're left with, and you treat those things. They become sort of the loudest voice in the choir, and slowly but surely you just keep backing off of those pain medications. But the pain meds, many times will allow me to do things where if you were to, stop the pain medication and then come in severe pain, and I try to even lay a finger on you, and you're in such terrible pain from that, just that finger lightly touching you, well, you're not going to tolerate very much physical therapy. As you shared it, it said your question was, how long will it take to build these muscles? I'm sorry to say that that is a little bit individual from patient to patient. I mean, I could answer a nice, easy 6 weeks, but that's just not true. We've got clients where they have significant muscle atrophy, where I can tell them it will take longer. And then I have clients that have surprising muscle health, and you're looking at a very short period of time. So the range is quite wild, but certainly, there's sort of a saying within muscle training where, with 4 weeks of exercise, you notice a difference. With 8 weeks of exercise, those closest to you notice a difference, and with 12 weeks of exercise, others notice a difference. And so, but again, those kinds of, cookie-cutter answers are just that, and every person is very different and has their own individual needs. Is there much that can be done for pelvic pain without starting with spinal manipulation? I have thin dura and had a spontaneous cerebral spinal fluid leak and have been told to avoid any spinal manipulation for this reason. Well, we most certainly would not even touch your spine. If I were a physical therapist and you told me that, I wouldn't go near your spine. I would be very cautious. As you noticed within our algorithm, we have quite a few tools in our basket. For all kinds of other reasons, I have not been able to work on someone's spine. They may have EDS, but they also may have severe osteoporosis, and any pressure on the spine, I risk fracturing the patient. There's been all kinds of reasons that I've avoided the spine. Some patients just have severe sensitivity to touch of the spine. Well, of course, that's not a tool that I choose to use at that point in time. I stay far, far away from the spine if a client has any risk, any known risk, and even any potential risk. It's just simply that it was an option that many times is not addressed when treating the pelvic floor. But certainly in your case, yes, there are loads of treatments. Again, if you have the tendency to have such a thin dura and spontaneous cerebral spinal fluid leak, really with you, the path would be very cautious in general. That would be my method. No, not a question. If you lose cervix in hysterectomy, may lose ability for orgasms, especially if multi-orgasmic. And that has happened. That has happened to some of our clients. That is true. And some of our clients, though, report continued orgasm if they lose both. For a coccyx that is side bent, does it help to exercise the pelvic or buttock muscles on the opposite side? Sometimes. Yeah. Again, back to the person that has severe pain, maybe. But yeah, sometimes what we do as physical therapists is we will cue the side we want to contract harder. Very difficult to really isolate one side from the other, but you can help one side contract a little bit more fully than the other. Why would a coccyx regularly deviate to the left after I tighten the buttocks? I can't answer that for sure in your case. It is very interesting that it seems to pick a side and stick to that side. It may be because of injury. Who knows? You had it when you were a toddler and fell down on your bum when you were trying to learn to walk. Our body remembers injuries, and ligaments will stretch with these injuries. And unfortunately, once a ligament does stretch, it doesn't self-correct without proper treatment. So I don't know for sure why yours would regularly deviate to the left without knowing your whole story, but it is a challenge for us as physical therapists to change that. Does intercourse pain impact fertility? Or if you have pain, is it a symptom of issues or complications you may have with potential pregnancy? The answer is no. We have had patients just grin and bear it and get pregnant very quickly. It does not impact fertility necessarily. And if you have pain, you yes, it can indicate potential complications with pregnancy, but it may not. I think one of the worst pelvic pain patients I've ever treated had wonderful pregnancies, and we all felt that the elevated estrogen for her was just lovely and really helped out her particular symptoms. What is the best type of SI brace to get, and should it be used during intercourse? That depends on the positions that you're choosing for the SI brace. There are certain positions of intercourse where if you remain in relatively one or two positions that are well supported of the SI joints, then you shouldn't need to use the brace, even with the rocking back and forth. However, if you wish to have a little bit more variety and movement, then yes, I would recommend it and applaud any partner who doesn't allow such a thing to sort of ruin the sexuality of the event. The best type of SI brace, again, it's different for every client. We tend to prefer the Sorolla belt here at Her Health Physical Therapy. It's just one of our favorite braces, but again, if a patient tries it and they say, I didn't like this, well then we would certainly go potentially to the SI lock belt, both of which again have been helpful for various patients. So I think I got to the end of them.
That was your last question. Wonderful. Yeah, those are the two braces that we've had the most experience with our members too. I assume the SacroLock, you're talking about the Biofeedback brace?
Yeah. Mm-hmm.
Yeah. So those have gotten good reviews. I think the Biofeedback brace is a little bulkier, a little bit more depth to it, and I think the Sorolla is a little more subtle.
That's correct.
If that matters to anyone. Okay. Well, thank you so much, Jennifer. You've given us an amazing wealth of information. And do you have any other last thoughts or any other information? We can include some information on the articles that you mentioned. We'll put those along with your recording on the same announcement page that people use to log in. So if anyone, missed that information, we'll include that on the website.
Okay, that sounds great. Thank you so much.
Super. Thank you so much for your help. And wanted to remind everybody that on the 15th, we're going to have Dr. Stoller speaking for us. She's the geneticist at Boston Children's Hospital, so don't miss that. And on October 6th, I believe it is, we're going to have Ellen Smith speak for us. So you can go to our webpage to the webinars tab to get the upcoming schedule, or you can log on to get the free report, and you can receive those announcements on your email.
Yeah, again, we appreciate everyone attending and your patience as we get started, and it's already almost 2 hours, and we appreciate everybody's attending our session. Want to remind you that this program is sponsored by Body Support Store, where there's over 250 products that were selected by EDSers for EDSers. We have a wide range of the Biofeedback braces, a lot of unique pillows and other wedges and items that you might be interested in. So feel free to check those out, and that again is what funds our free program. So please go to that site. And we really appreciate everyone attending this evening, and appreciate Jennifer's presentation. Very interesting and thoughtful topic that we really hadn't addressed before. So it's really incredible. So yeah, our store site is bodysupportstore.com. So check it out. So I'm going to call it the evening. So everyone have a good evening, and we'll see you next time. Good night.
Good night, everyone.